Welcome to Scalpels and Sutures, the official YouTube channel of the Department of General and Minimal Access Surgery at GMC Patiala. In this series, we will take you through step-by-step tutorials on clinical examination in general surgery, thoughtfully designed to support both MBBS students and postgraduate trainees. Guided by our expert faculty, you will learn essential examination techniques in the real-world clinical practice. Join us on this journey towards becoming a more skilled, confident, and competent clinician. Before moving forward, we must always begin with proper history taking as highlighted in our previous video. A thorough history lays the foundation for accurate diagnosis and effective management. If you haven't had the chance to watch that session yet, we highly recommend revisiting it. The link to the video titled Decoding Pain, a surgeon's approach, is given in the description below. Once you have mastered that, you are ready to proceed with the examination techniques we will discuss today. Examination of abdominal pain. When examining abdominal pain, it's not just about the steps, it's about how carefully you do them. Each step has important points you must keep in mind to avoid missing a vital clue. Make sure the patient's lying comfortably, abdomen exposed from nipple to mid-thigh. Observe any asymmetry. Even a small bulge may indicate hernia or mass. Look for distension, whether generalized or localized. Don't ignore skin changes like redness, dilated veins, scars, or sinuses. Always check for a cough impulse at hernial sites. Inspection must be done slowly and systematically. If you rush, you may miss a scar, a vein, or even a bulge that tells you the whole story. Always auscultate before palpation and percussion to avoid disturbing the bowel activity. Listen in all four quadrants for at least 30 to 60 seconds. Complete absence of sounds seen in paralytic ileus. High-pitched tinkling sounds seen in mechanical obstruction. Normal activity can be seen even in hyperactive or hypoactive stomachs. Never conclude too quickly. A silent abdomen needs time to confirm. Listening carefully may be the difference between missing an obstruction and diagnosing it early. Percussion. Percuss gently but widely over the abdomen. Dullness nod. You can elicit in fluid, mass, or organomegaly. Tympanic nod. Seen in distended bowel loops or free air. Always check for shifting dullness in suspected ascites. Compare both sides for consistency. Percussion is subtle. You must compare and confirm. Even a faint change in note can point toward different diagnosis. Palpate gently but deliberately, firmly and with purpose. Always start from the tender area, then approach the painful spot. Warm your hands and place your entire hand with fingers together and extended. Apply pressure with palps, not the tip of the fingers. Begin with light palpation first. If tolerated, go deeper. Move systematically from left iliac fossa anti-clockwise to the right iliac fossa. Keep your hands still and let the organs move beneath. Watch the patient's facial expression while palpating. They may reveal tenderness even before the patient speaks. Palpation is not about pressing hard, it's about pressing smart. A gentle, systematic approach is what helps you pick up real tenderness and masses. So the golden rule is be systematic, be gentle, and don't miss the small details. In abdominal pain, even a scar, a faint bowel sound, or subtle change in percussion note can be the clue to the diagnosis. What is the differences between tenderness, guarding, rigidity, and rebound tenderness? Tenderness is simply pain when the examiner presses the abdomen. On examination, the patient says ouch or winces when you apply pressure. It is non-specific. To elicit tenderness, you gently press on the suspected area of the abdomen and watch the patient's facial reaction. Next is guarding. This is a voluntary contraction of the abdominal muscles. It happens while you are pressing, often because the patient is anxious or in pain. You will notice the abdominal wall tightening under your hand. Clinically, guarding may suggest an early sign of peritonitis. But remember, it can also be due to anxiety, so you must interpret it carefully. To test it, place your hand gently on the abdomen and press. You will feel the muscles stiffen while you apply pressure. Now comes rigidity, which is much more serious. Unlike guarding, rigidity is persistent involuntary muscle spasm. Here, the muscles are already tight before you even press. This creates a board-like abdomen, which is a strong indicator of peritonitis, often a surgical emergency. If you find rigidity on abdominal examination, you should suspect peritoneal irritation and act fast. Rebound tenderness. This means pain on sudden release of pressure. The patient actually hurts more when you remove your hand quickly than when you press. It's a classic sign of peritonitis, and you can elicit it by pressing gently into the abdomen, then suddenly letting it go. The patient will experience sharp pain on release. Briefly, tenderness means hurts when you press. Guarding means voluntary tightening while pressing. Rigidity means involuntary, constant board-like tightness. Rebound tenderness means it hurts more when you release. These simple bedside signs are still extremely powerful in diagnosing surgical conditions, so always practice them carefully during clinical examination. Your examination is incomplete if you don't check beyond the abdomen. Palpate the supraclavicular fossa and neck for enlarged lymph nodes. Examine the hernial orifices. Check for femoral pulses and inspect external genitalia. A rectal or vaginal examination is essential when indicated. It may reveal findings that the abdominal wall cannot show. Now let's take a quadrant by quadrant tour of the abdomen and understand the important differential diagnoses associated with each region. We will divide the abdomen into 4 quadrants: right upper, left upper, right lower, and left lower. Right upper quadrant. The right upper quadrant houses the liver, gallbladder, part of the pancreas, duodenum, and hepatic flexure of the colon. Common conditions include peptic ulcer, usually with burning epigastric pain; pancreatitis, radiating pain to the back, often severe; liver abscess, fever with right upper quadrant tenderness; gastroenteritis, diffuse pain with diarrhea and vomiting; mesenteric ischemia, severe disproportionate pain. Intestinal obstruction or inflammatory bowel disease can also present here. Pain here can point towards hepatobiliary or gastric causes. Left upper quadrant. In the left upper quadrant, we find the stomach, spleen, pancreas, and splenic flexure of the colon. Gastritis, burning epigastric discomfort. Pancreatitis, just like in right upper quadrant, but can also localize here. Splenic rupture or enlargement, often after trauma or infection. Myocardial infarction. Don't forget that left-sided chest pain can radiate here also. Pneumonia. Lower lobe infections can mimic abdominal pain. Inflammatory bowel disease or intestinal obstruction are also possible. So, left upper quadrant pain makes us think gastric, splenic, and sometimes even cardiopulmonary causes. Right lower quadrant. Now let's move to the right lower quadrant. This area contains the appendix, terminal ileum, cecum, part of the urinary tract, and reproductive organs in females. Appendicitis, the most classic cause of right lower quadrant pain. Intestinal tuberculosis or terminal ileitis, chronic conditions that mimicking appendicitis. ectopic pregnancy or ovarian cyst torsion in females, ureteric calculi, sharp radiating pain. Hernias can also cause localized pain. In clinical practice, right lower quadrant pain is often a surgical emergency until proven otherwise. Left lower quadrant. Finally, the left lower quadrant, which includes the sigmoid colon, part of the urinary tract and reproductive structures in females. Pain here may arise from diverticulitis, the most common cause especially in older patients. Ectopic pregnancy in females. Constipation, a frequent but often overlooked cause. Nephrolithiasis, kidney stones passing into the ureter. Psoas abscess with associated back pain. Hernias are also important to remember. Left lower quadrant pain usually points towards colonic or pelvic pathology. What to look for? Clinical signs are simple bedside tests that can give us vital diagnostic clues in abdominal pain. Each sign has its own characteristic finding, and when elicited properly, they can point us toward the exact underlying condition. Let's review the important ones. Balance sign. Dull percussion not present in both flanks. Constant dullness on the left side. Shifting dullness on the right side with position change. Seen in ruptured liver. Kehr sign. Left shoulder tip pain when patient is in supine or in Trendelenburg position. Pain may appear spontaneously or after pressure on left subcostal region. It indicates hemoperitoneum, commonly seen in splenic rupture. Cullen sign. Bluish discoloration around the umbilicus suggests intra-abdominal or retroperitoneal hemorrhage. Classic example of hemoperitoneum in ruptured ectopic pregnancy. Grey tunnel syndrome. Local bluish discoloration over flanks indicates retroperitoneal hemorrhage, seen in acute hemorrhagic pancreatitis or aneurysm rupture. Damp sign. Empty right iliac fossa on palpation. Mass in epigastrium with slight retraction of right iliac fossa, strongly suggestive of intussusception. Fothergill sign. Abdominal wall mass that does not cross the midline. Mass remains palpable even when rectus muscle is tense, indicates rectus muscle hematoma. Ten-horn sign. Pain in right iliac fossa on spermatic cord traction, suggestive of acute appendicitis. Murphy's sign. Patient in sitting position. On deep inspiration, while palpating right hypochondrium, sudden pain and patient winces. Diagnosis of acute cholecystitis. Moynihan sign. Same as Murphy's test but done with patient lying down. On deep inspiration, palpation of right hypochondrium, pain and wincing will be there. Indicates acute cholecystitis. Obturator sign. Patient in supine position. Flex right thigh at right angle to trunk. Externally rotate the same leg. Causes hypogastric pain. Suggests pelvic appendicitis. Ileus sign. Patient lies supine. Elevation and extension of the right leg. Done against resistance from examiner's hand. Produces pain in the right iliac fossa. Suggests retrocecal appendicitis. Rovsing sign. Apply pressure over the left iliac fossa. Gas and contents are pushed toward the cecum. Produces pain at McBurney's point. It is suggestive of acute appendicitis. Aaron sign. Apply firm continuous pressure over McBurney's point. Patient experiences referred pain or distress in epigastrium or precordial region. It indicates acute appendicitis. London sign. Bruise over abdomen with distinct imprint or pattern caused by sharp, severe blunt force impact. Suggests blunt trauma abdomen. Don't miss these points. The patient should be asked if there is any special time of appearance of pain. Sometimes an interval of days, weeks, months or even years may elapse between two painful attacks. Severe pain may be associated with pallor, sweating, vomiting and increasing pulse rate. Abdominal pain demands a careful step-by-step approach, starting with inspection, auscultation, percussion and palpation. then narrowing the diagnosis quadrant by quadrant, and finally confirming with classic clinical signs. This systematic examination not only helps us reach the right diagnosis, but also prevents us from missing subtle but important clues. Thank you for being part of this session, and I hope to see you again in our future discussions. Click on the link in the pinned comment for getting a handout on examination of pain. Subscribe to this channel to get notified for further informative videos.